Good afternoon. My name is Lexi Furnish, and I will be talking to you a little bit about clinical prediction rules. First, we're going to go over an article written by Simon Adams that explains what exactly clinical prediction rules are, why we would use them. First of all, we're going to look at why we would use them, why they are beneficial in the healthcare profession. They ultimately can save the clinician time, which can save the clinician or their employer money by allocating the necessary time and energy to those that are seen to be more likely to actually have the issue at hand. So I looked at DVTs explicitly. Therefore, the physician that is addressing it will only need to use his time to evaluate and an ultrasound to diagnose those people that are seen as moderate or high risk for DVTs. Also, these models can identify the possible problem before it increases in complexity. So for DVT, you can identify those that have a moderate to high likelihood of having a DVT before that DVT has an opportunity to possibly break off and cause a stroke or an embolism or something that could potentially be life-threatening. So again, ultimately it saves time, money, and possibly lives. So now we're going to look at some of the components of the reliable prediction factor model. So first, we're looking at sensitivity. A good factor model would be able to include as many patients that are likely to have that issue as possible. So for DVT, we want to create a model that brings in and identifies as many people as possible that could possibly have a DVT. And then conversely, on the other hand, you have specificity, which means you also want to be able to exclude the people that are at a low likelihood for having that condition. These two things are mutually exclusive, so as a sensitivity of a model increases, the specificity decreases. So at this point, it's more of a balancing game. You want to include as many and exclude as many, but you're not going to have 100% on both. Also, to have a positive predictive factor model, it obviously needs to be accurate with its predictions, and then to have a good predictive factor model, the theorized probability of someone having a condition and the observed outcomes need to align. This is kind of an obvious principle. If you have a theory that actually theorizes incorrectly, that's not going to be good predictive factor model because we want to have tools that are accurate and reliable. So then, when establishing CPR, there are 4 factors that you really want to focus on. So first, the development. You have to be specific in what you are trying to do with each CPR. So then you also need to look at the validation. So who? This you want to test in separate and different populations to see if the CPR is reliable when it comes to populations such as the young or the old or the immobile, making sure that it can be generalized to multiple populations. Thirdly, you want to look at the impact analysis. So basically you want to see if it's useful in a clinical setting. This can have to do with cost benefit. Is this going to be cost effective for the benefit that you're able to get out of the CPR? Does it increase patient satisfaction? Is it good use of time and resource allocation? And then lastly is implementation. So once you develop the previously mentioned 3 factors, then we can look at implementing it. We can see whether it is accepted or adopted among different healthcare professionals. So here are some pros and cons of using a CPR. So a pro is obviously a statistical algorithm or model is going to be able to grasp all the varying factors better than the human brain. It's going to be able to consider and comprehend those in a more accurate way. Also, speaking of accuracy, using a statistical model, you're going to get the same conclusion every time because that is what it's there for. You are never going to get one model saying this and the other saying that. If they are good predictive models, they will both say the same thing. That doesn't always happen with a clinician, especially if you have someone that's very inexperienced, because they aren't able to, first of all, gather enough information. It also could be that they aren't able to comprehend it. They aren't able to put the puzzle pieces together in just the right way to get the appropriate outcome. But on the other hand, the cons, a lot of times these models aren't user-friendly because they tend to be on the complicated side. They also are able to comprehend better than the human mind, but they're not able to always recreate the continual and dynamic way in which the human mind gathers information, which can be a very positive attribute when decision making. And lastly, it can be a con that there are just so many models for each condition that the clinician has to be able to discern which CPR is the best for each condition. And also, there are so many ways for each of these models and tools to be developed that it just adds to the number of models that are accepted and adopted. So there are 5 types. There's a scoring, which is the one that my Wells DVT criteria is. There's the multivariative analysis, which is similar to scoring. And there are the nanograms, which is graphical calculating device that represents mathematical relation or law. This is actually has a bonus because the final product is normally comparative to the other, simple to use, and in some cases more accurate. So that's a win-win. Fourthly, you have the artificial neural networks. So this compares the way you're able to make your decision to the nervous system. It receives input from different sources. It processes all the information and sends the quote-unquote action potential or not, depending on the information it's gathered. And then all cells are interconnected. Lastly, you have the decision tree, which is a flow chart. It's also a little bit more easy to understand. So then specifically, like I said, I looked at the Wells criteria for DVT. Like I said before, it's a scoring type. The DVT has been chosen to be an important indicator of the quality of care, so it's highly important for there to be a low level of DVTs in different clinics, hospitals, things of that nature, because it's said to be preventable with appropriate detection and prophylaxis. So in order to be able to detect all of these so that you keep your facility at a high level of quality of care, they would increase the ultrasound scanning in asymptomatic trauma patients, which was not cost effective or not cost efficient or time effective, because you have to pay for that testing, plus you have to pay someone to provide that testing, someone to read the results. So again, it's not super cost efficient or time effective. So in order to kind of correct that, what they did is they took all the patients coming in with some kind of trauma and they gave them this Wells criteria. So here you see there are different clinical characteristics. If they have it, they get a 1, or as you see at the bottom, a -2. And then after going through this survey, you get a score. So a -2 to a 0, you are at low likelihood. 1 to a 2, you're at a moderate likelihood. And if you score from a 3 to 8, you're at a high likelihood of developing or having a DVT. So they also found this to be reliable. With the low population, there was 0 occurrence of DVTs. With the moderate population, there was only a 7.3 occurrence, and with the high, there was a 66.6% occurrence. There was a strong linear correlation between the Wells and the incidence of DVT, with an R value of 0.94. And then it is said that Wells was able to detect with a specificity of 90, which is meaning that they are able to exclude 90% of the people that don't have DVTs. And then it also was said that the Wells was able to detect with a 67% sensitivity, meaning they're able to catch 67% of DVTs just with these questions in this survey, which is very high, because like we said, these are mutually exclusive, so a lot of times you're not going to have that high of a number. So ultimately, what does this mean for athletic trainers and the athletic training field? I think as we move into the healthcare professional category and move out of the tech category, we as healthcare professionals need to be able to use similar tools as other healthcare professionals. We need to be able to understand these better so that we can also use them. DVT is actually a very scary thing, but it's also very prevalent, even though it's not a normal orthopedic injury, but also to be able to use the orthopedic CPRs so that we can kind of figure out who among our athletes are able or are most likely to get specific injuries or pathologies, and who maybe aren't as likely to get those pathologies. So like I said, in order for us to be taken seriously as healthcare professionals, we need to be able to understand some of these more complex tools that are used in the healthcare field to make us better clinicians and healthcare providers.